Yeah, you're not going to do a biopsy. A doctor is, and a lumbar puncture is level 4. So the treatment goals: shrink the tumor size. How am I going to do that?
Radiation.
Radiation. That's the number one choice of treatment, is radiation. We're trying to at least shrink that space-occupying lesion to a smaller mass so that it's not causing as many deficits. I want to improve this person's quality of life. If they're having some balance issues, I want to provide equipment that enables them to still be mobile but safe at the same time. And then another goal is to extend their survival time. Radiation is the top treatment of choice. Chemotherapy is sometimes used, but it is used very limited. Why? It's not effective. Why is it not effective?
You can't get to it.
Blood-brain barrier. It prevents the chemotherapy molecules from getting where it needs to go anyway. So if they do use chemotherapy, they do it with a ventriculostomy, and they put it directly into the brain tissue. So it's not that effective. They don't use it. Brachytherapy, does anybody know what that is? Brachytherapy is when they go in and they plant the little radioactive seeds. And they can do that for multiple kinds of cancer. They can do it for like prostate cancer, brain tumor. They actually go in and plant the little radioactive seeds into the tumor itself and hopefully kill the tumor that way. Mm-hmm. I didn't hear you. Is it effective? Yeah. Yep. And a craniotomy is a level 4 thing. That's where they go in there and they dig around and hopefully remove only the tumor and leave my brain tissue intact. But like I said, some tumors going to remain with the little fingers, or they're going to remove some brain tissue to get all the tumor out. So surgery is like a last resort, unless they're sure they can really do a good job without causing more deficits. Okay, that's all I want you to know about brain tumors. Taking up space where it doesn't belong. My symptoms are based on the location of my brain tumor. What am I going to do if my patient has an angiogram to keep my patient from any kind of complications? Okay? Seizures. Well, 4 pages. I'll limit it down to 4 pages. Okay? We're talking about seizures. So, there's a difference between seizures and epilepsy. And the book defines them this way, okay? A seizure is a sudden, excessive electrical activity of the brain one time. Epilepsy is when you have 2 or more seizures of that kind experienced by the same person. So, you know, when a little 4-year-old has a temperature of 104, can they have a seizure?
Yes.
It's a febrile seizure.
Yeah.
Are they an epileptic? No. They had a febrile seizure. So there's different classifications, but we're really talking about the patient that has a history of seizures. So they had 1, 2, 3, 4, and they're on some sort of medication for the seizures. There's different kinds of seizures. These are all in your book. You can look at them. Generalized is the seizure you normally see on TV when you see someone having a seizure and they're jerking all around and stuff. A focal seizure, parents say that kids have them sometimes where they just zone out and they just stare off into space and then all of a sudden they're back. That's a focal seizure. Yes, what's your
So with epilepsy, do you have to have something specific that causes it?
We're going to talk about that.
Okay.
Causes.
Okay.
And then there's some seizures, they just don't know what causes them. Okay? They just don't know. These are no seizures. So, just like your migraine. Some people have an aura with their seizures. They know it's coming. Okay? The ictus state is the seizure itself. You just need to know these terms in case you see them. Okay? I don't really care about this stuff, but you might see it on NCLEX. I really care about what you're going to do to keep this patient safe. But you might see these terminology, so I put it up here for you. Post-ictal is after the seizure. If your patient has a generalized seizure, what do you think they're like afterwards?
Drowsy, confused.
They're drowsy, confused. Having a seizure is a lot of work, and they are out of it for a little while. Sometimes they'll have some incontinence. Sometimes they're hard to wake up. You know, yes, ma'am.
Can an aura be like a sensation? So like my cousin, he has epilepsy and his arm will go numb.
Yep.
So they always call his parents at school when that happens.
Yep. Because there's really nothing you can do to prevent it at that point, but at least you know it's coming. Yeah, we had a patient at Biloxi Regional one time, and he was so sensitive to his medications. He took such a small dose, and he took it on time every time. If you were 30 minutes late, he would have a seizure. That's way too close. You know what I'm saying? Because what if you can't get to your medication or something comes up, you know? But literally, he was so regulated that if he missed his dose by 30 minutes, he would have a seizure. He had the best seizure I ever saw. It's great. I'm just telling you. And my friend was pregnant. She's like, could someone help me before he kills the baby? Because he was all over the place. Okay, so you gotta know what kind of factors can cause your seizure, and you gotta know the difference between a seizure and epilepsy. Okay, you just need to know what the differences in those are. Your history. Have you ever had a seizure before? How long did the seizure last? Is that important? How long it lasts? It is important. That's part of what you're going to do as the nurse when we get to that slide. CAT scan, MRI. You all can send me down safely to have that. You know what to do. An EEG. I've never had one before. What do I need to know? What do I need to know? Anything?
A lot of stickers on your head.
Okay, I'm going to have a lot of stickers on my head. What else? They can do it when I'm awake or asleep. It just depends on what they're looking for. What else do I need to know? Do I need to eat or not eat?
You can eat.
You can eat because if your blood sugar's low, do you think that could trigger a seizure?
Yeah.
Yeah, so I want you to eat. I want your blood sugar to be normal. What else do I need to know? Do I need to ride home? Nope, I'm not sedated because if you sedate me, how you gonna know if I'm having brain activity? So, no sedatives. Do you think you want to take your seizure medications though? Yeah, I'm trying to see if your seizure medications are working. So if you're not taking them for a week before the test, how am I really knowing if they're working or not? So I want to take my regular seizure medications, but I don't want to take any pain medicines or anything that's sedating because that'll affect the test. I want to eat because my low blood sugar is going to affect the test. All those little stickers on there, you think you might need to talk to your patient about anything before you put those stickers on?
Are they allergic to anything?
Okay, and Mike, are you allergic to any kind of tape or stickers, anything like that? What else? What'd you say? It's gonna pull your hair out, probably, yeah. Are they gonna stink if you're all greasy and oily? No, I need you to wash your hair. I need your hair to be clean and dry when you come in here, because I'm gonna stick all these little stickers all over you, and they're not gonna stick, and I'm not gonna get a good reading if they're not on you. So clean, dry hair when they come in to have this done. So, you think you could send him down for an EEG? You know what to do? What to look for? Yeah, you do, because we just talked about it all. So, I'm gonna eat, gonna take my regular pills, not gonna take my pain medicine. You're not gonna sedate me, so I can drive myself home. I don't need a driver to take me home. And I need to come in here with clean, dry hair, so those stickers stick to my head. You need to learn all what those little lines mean over there? Nope, you don't, because somebody else is gonna read that. All you gotta do is make sure that this patient's prepared. Seizure precautions. What kind of things do you need to think about if you know you have a patient who has seizures?
The bed in the lowest position.
My bed needs to be in the lowest position. What else?
Padded rails.
Loose clothing. I don't want them to be able to catch themselves on something and choke themselves or get caught up on something. What else?
Suction.
I need suction at the bedside because what if they vomit during the seizure? I need to be able to get it out of the way. What else? Okay, that's the one I want to talk about. Every facility on the Gulf Coast has their side rails. Your book says to do what the facility does. So padding the side rails is not actually a recommendation anymore, but it is what every clinical site that we go to is going to pad the side rails if you have a patient who has seizures. So he's having a seizure. What's my responsibility as a nurse?
Safety.
Safety. So I walk in the room and I'm getting my little meds ready, my little Pyxis machine or whatever, and all of a sudden I see out of the corner of my eye he's having a seizure. What do I need to do?
Go in
Call
there.
him.
Make sure he's
Okay,
got open airway.
I need to stop what I'm doing. I need to get some help. But am I going to let him alone?
No.
No. I'm going to hit the call light. I'm going to yell out the door, whatever. I'm not going to leave him alone. Because when I call the doctor and say, Johnny had a seizure, he's going to say, well, what time did it start? How long did it last? What did you observe? So you are the person in the room who's protecting this patient's safety and documenting everything that happens so you can relay that information to the doctor, okay? What do I want to put in his mouth?
Nothing.
Nothing. Not your fingers, not a stick, a tongue depressor, not a bite block, nothing. They are strong. They will bite your fingers off. Do not stick anything in their mouth. So, Johnny might swallow his tongue.
Oh,
I
well.
assure you that does not happen, okay? You can't swallow your tongue, okay? So you don't stick anything in their mouth at all. Turn them on their side when the seizure's over. Do I really want to mess with them when they're having a seizure and try to restrain them? No, I don't want to restrain them because I think to cause more harm with them fighting me. But once the seizure's over, I want to turn them on their side to make sure that if they vomit, they don't aspirate, and then just kind of watch them until they wake up. So my responsibility is to provide safety, and if it's a room with 2 patients, privacy, because this dude in the next bed doesn't need to be observing everything. And I don't think anybody has double rooms except Keithler anymore anyway. Memorial does. But I want to turn him on his side. I need to have oxygen in there just in case I need it, suction just in case I need it. But think about the safety things. Bed in the lowest position. You're not going to leave him though. You can get help another way. Call them, use the call light, go out the door, get help another way, okay? Pick up the phone, call the desk, whatever. We're going to talk about meds real quick. Here's the rules about seizure medications. When they go to the doctor and get put on medications, they're going to institute one medication at a time. Does that make sense? Because if I say, oh, you had a seizure, let me give you these 3 medications. You might not need 3 medications. One medication might work for you. So we're always trying to treat this problem with the lowest amount of medication, okay? Or you might have an allergic reaction. I don't know which one you had an allergic reaction to because I gave you 3. So they're going to initiate one medication at a time. Seizure medications have a lot of drug and drug-food interaction. So you need to be aware of that, which ones, and on the next slide, I tell you which ones you need to be concerned about. Almost all seizure medications need blood levels drawn. So let me ask you this. If you're teaching your patient something about his seizure medication, you can only teach him one thing. Which one's more important? You need to take your seizure medication every day at the same time, or you need to come in here every 4 weeks and have your labs monitored. The labs, because I can take my pill every day, but if it's not the right dose, I'm not going to get to a therapeutic range. So when you look at those priority questions, this is how I want you to say to yourself, I can only teach this patient, or I can only do one of these 4 things, because they're all right. If it's a priority, they're all right. You're going to do them all. But I can only do one. Which one is my patient going to die if I don't do? That's how you need to ask yourself those questions. Because I can only do one of these things. They're all important, but I got to choose. So monitor their blood levels, because I can take my pill every day, but it might not be working because it's not the right dose. And then to maintain the therapeutic blood levels, what do I need to teach them about taking the medicine? Right. I want you taking it at 6 a.m. today, at 1 o'clock in the afternoon tomorrow, and then 6 o'clock in the morning, and oh, geez, I forgot I'm taking it at night. Am I really going to get a nice, steady therapeutic level? No. It's a medication that you need to take every day, on time, every time. So, anti-epileptic drugs. Here's a list of their names. You probably know them by other names because your patients are going to call them Dilantin or Keppra or Neurontin, things like that. These are the names that are going to be on your test, though. This is what I want you to know about them. They got to have labs monitored. 2 kinds of labs. That green tube up there is for my therapeutic drug level, okay? The purple tube is because a lot of these seizure medications can cause bleeding problems. So I want to monitor my platelets, okay? See the nasty mouth up there? A lot of these medications cause gingival hyperplasia. So what do I need to teach my patients? Oral care. You need to brush and floss. You need to visit the dentist regularly. You need to really take care of your teeth. the clock, on time, every time, okay? Take my medicine same time of day, on time, every time. This little blue pill, you probably can't see this from your seat, that's Coumadin. Coumadin and seizure medications potentiate each other. So if I'm taking Coumadin and all of a sudden you're putting me on Vitiated, which is this dilantin, what do you need to tell me? Well, I have to. I have stents in my heart. No. What do I do when I take Coumadin? I go have therapeutic levels drawn. So if my dilantin is making my INR come up, I can decrease my level of Coumadin. But how am I going to do that if you don't check my blood? So I have to monitor my blood to make sure that I'm on the right dose of Coumadin. It doesn't need to be adjusted. I have to take my Coumadin. My stents will clot and I'll get a heart attack. You know, we teach them that, and then you're going to say you can't take it. They'll freak out. And the other one is grapefruit. Just get this in the back of your head. Grapefruit juice and medicine just don't go together at all. So just get that in the back of your head. And the other thing is, it's not up here, antacids. If you take antacids like you eat Tums, like, you know, M&Ms, they interfere with the absorption of medications. So you can't take your antacids with your medications, okay? So those are the things you need to know. I'm just going to tell you, EB9 has simplified this stuff because it used to be all these crazy things for this med and all these crazy things for that med. Now it's just one big generic concept. Seizure medications, these are the 5 things that you need to be aware of and teach your patient about. So they made it pretty simple. Status epilepticus, we need to know what that is. That is a prolonged seizure, a seizure that lasts more than 5 minutes, or your patient had a seizure, it's over, you call the doctor, and 2 minutes later they're having another seizure within 30 minutes. This is an emergency, because if my brain is all active with my seizure activity, what's happening with my neurological status? It's going down. So it's an emergency. So, see this slide right here? I'm going to tell you what to do. You've got to stop the seizure. So these medicines right here, they ain't going to stop a seizure. These are preventive, everyday medications. They're not going to stop it. So you are going to call for help. That is the first thing you need to do because you've got to get some help in there. Okay? You are going to give some medication, diazepam or lorazepam. And that is Valium or Ativan. I know y'all know the other words. So how am I going to give that? My patient's having a seizure.
IV.
Push your
IV. Well, IV push is preferred, but you can't give an IM if they don't have an IV. That's why they like every patient in the hospital to have an IV, emergency access. You can give it IM if you have to. Who can give it IM? The LPN can. Who can give it IV? Only the RN. The LPN cannot push a medication like that. Then you got to think about your safety while you're doing all this. You got to find the cause. What's causing the seizure? Is it increased intracranial pressure? Is it alcohol problem? Is it a lab that's out of whack? Which lab can cause seizures if it's out of whack? Calcium can and sodium can. So is it a lab that's out of whack? And then you got to figure out, after you get it stopped, your preventive medications are phenytoin or fosphenytoin. And those are given IV to your patient. You'll go home with them. But they don't stop the seizure. To stop the seizure, you've got to use either diazepam or lorazepam. And that's the most important thing, is to get the seizure stopped.
So you said both of those were push preferred.
Yeah, they preferably, but if your patient has no IV access and they're having a seizure, you're not going to get one. You can give them IM. Okay. Just be careful not to stab
Would you call
yourself.
the rapid response team first and then administer the drug, or would you do the?
Well, you're going to call the rapid response team because you're not leaving him. I need RRT and I need somebody to bring me some diazepam. You know what I'm saying? You're not leaving him while he's in there. So, yes, you got to get help. That's your first thing. You've got to get help. This is a vagus nerve stimulator. I've only ever seen this one time on a little girl that had seizures, and her mom said it didn't really work, but they can implant this pacemaker-like thing that stimulates cranial nerve 10 and supposedly helps stop the seizures. Like I said, I've never seen one, but it mentions it in your book, so I wanted to tell you it is a treatment out there. The other thing that they have now are dogs. So they have service animals that can pick up on the aura and the scent and alert you that the kid or the adult's going to have a seizure. So that's another thing that they're doing now. Spinal cord problems. I know I'm going kind of fast, but I want to get to a certain point today. And if you have a question, I will stop and answer it. But I mean, this is kind of simple, and I'm giving you everything you need. Really, truly, use the PowerPoint, and then if you have a question about something, go look it up in Iggy, and you won't get lost. I mean, don't you think on 170 slides I gave you everything you need for your test? Yeah. Hello.
Thank you.
Spinal cord problems. Okay, we're going to talk about those. Anatomy. You remember the spinal cord? Spinal cord runs up through the vertebrae in there, and it's protected by the bone and then cerebral spinal fluid. So you also know that you have the nerves. When I put my hand underneath that over the candle right there, how quick that relay is to go to the brain and says, get your hand away from that, you're going to get burned, or you already did get burned. So we're talking about a disruption in one of these nerves here that's causing the problem. The dermatomes, you know that where your level of injury is. If my level of injury is low, my deficit's less than if my level of injury is high. Okay? And we're going to look at all these when we look at spinal cord injuries. Let's look at back pain. I already told you, number one reason people don't go to work, their back hurts. I wish that was my excuse, but. Okay, we're going to talk about two kinds. Lumbar sacral, which is your lower back, and your cervical spine, which is your neck. Okay? Those are the two most common places that you're going to have an injury. So, acute, what does the word acute mean? It's one little tiny event, you fell, your back hurts, it's gone. Chronic is what we're really talking about here, and that's repeated, recurrent pain for a period of time greater than 4 months. Here's your pages for back injuries right here. And you don't have to go read it all, just if you have a question when you're studying, that's where you're going to find your answers in that section of the book. Two problems happen with adults in their backs, and that is spinal stenosis, and I don't know if you can see this, but the gap where your spinal cord is used to be nice and open, and now it's kind of closing down, and it's causing pressure on your spinal cord. So if I'm causing pressure on my spinal cord, do you think I'm going to have symptoms? Yeah, this happens a lot in the elderly patients where they have the chronic low back pain, and they'll do an MRI, and it shows that that's closed, and there's just no space for the spinal cord. And then a herniated disc. How do those happen?
Accident.
Falls, bending and twisting. You can do it that way.
Car wrecks, too.
accidents, things like that. And they can happen in the lower back or the neck. Your symptoms are persistent pain, weakness in an extremity, like I don't know why, but this leg is, or I can't lift anything with my left arm. They'll have persistent weakness. They may have some pain. What's paresthesia mean? Numbness and tingling. Problems with ambulation, where they just either can't lift their feet or they stumble because their balance is off related to this. Bowel and bladder problems. If it's low enough on your spinal cord, you can have some bowel and bladder problems. You're going to diagnose it the same way. You're going to find out, were you in an accident? When did these symptoms start? How long have they lasted? What kind of pain is it? Is it sharp? Is it dull? Things like that. There's a whole little section about assessing your patient and things you need to know. You already talked about CAT scans and MRIs. That's what they want to see. Now, they like to do this with the least invasive stuff possible. So you go to the doctor and he gives you a prescription for an NSAID, and he says you need to go home and rest, use some heat and some ice. Yeah, that doesn't work. So then they say, well, we're going to send you to PT to get you some exercises to strengthen your back muscles. So they go to PT, and you know, a lot of this is insurance driven. Because the insurance company is not going to pay for back surgery until you've exhausted everything else. So they send you there. Sometimes they'll use braces. The problem with braces is, if I am having a back problem and I am wearing a brace all the time, Right, I'm not strengthening my back at all, I'm actually weakening the muscles because I'm relying on the brace. So they don't do that so much anymore. They use some medications, they can use some narcotic medications or some NSAIDs, muscle relaxers, things like that. Epidural steroid injections, did y'all talk about that during peri-op? Where they go in and they do like a regional block or something? They can actually go in and go into the spinal column with the MRI and CT scan, see exactly where it is, inject some steroid right into that spot, and really, sometimes it works great, and sometimes it doesn't work at all. It just depends. Like at the surgery center where I work, the patient will say, "How long is this gonna last?" Because it feels good today because we numbed it up, and gave you some Versed, so you feel good. And you're like, it depends. It depends on how bad the injury was. It depends on how great the placement was when the doctor put the medicine in. And it depends on how good you take care of your back when you leave here. Because just because you feel good today and you go home and mow your yard, you're aggravating the problem even though you feel good. So this really depends on a lot of factors if it's effective.
And sometimes if they're injecting it and that's not the problem,
Right.
like cervical and shoulder,
Mhm.
kind of.
So when all of this fails, then your patient's going to have some surgery. Let's talk about these medicines first, though. Central acting muscle relaxants. Tizanidine is actually Xanaflex. That's Flexeril, Ribaxin, and Baclofin's Baclofin. What you need to know about these are they're really intended for short-term use. They're not intended for somebody to be on Flexeril for the rest of their life. They are addictive.
I don't know how people can function on Flexeril. I've taken one and I slept for 4
They
days.
don't do anything for me either.
Damn.
I pulled a muscle in my back one time. They didn't do a thing for me. They do cause some people drowsiness. Now, I have to admit, when I took a Flexeril, if I sat down in the quiet and did nothing, I would fall asleep.
Right.
But they do cause drowsiness. And you shouldn't take these with alcohol because alcohol potentiates the drug. And so the sedating effect of the drug plus the alcohol, you're more sedated. So what kind of safety things do you think you need to talk to your patient about? Don't take these meds and drive for sure.
Don't drink alcohol.
Don't drink your alcohol. What about I'm in the hospital and you gave me some Flexeril? What do you think you need to be looking at in my room? Fall hazards. There's a bunch of crap in hospital rooms. There's SCDs with tubing all over the place, and you got this pole that I'm hooked up to, and you got me 2 rails here, and my sheets are all over the floor. There's lots of little tripping hazards. So when I'm in there assessing my patient, I'm also cleaning up and putting things away so that when they get out of bed, what's the most important thing I need to tell them?
Call us.
Here is your call light. Please call me to help you to the bathroom. Well, I don't want to bother you. Well, I would like you to bother me rather than fill out paperwork because you failed, okay? So make sure that they can reach their call light and they know how to use their call light. So those are the things you need to think about if you're giving these meds in the hospital. Surgical intervention. The goal of surgery is not to make the person 100%, because as my little friend Dr. Chin says, you ain't getting any younger. I'm going to tune you up, but I can't get you back to where you were when you were 20. So the goal is to release the pressure where that's squishing in on the spinal cord and open that back up so they get some relief from the pain. So they can do a couple surgeries. A discectomy, they just go in and they trim off the herniated disc that's poking out and being squished between the 2 vertebrae. They just trim that all off and make it look nice and neat. They can do a laminectomy, where they actually take a piece of the bone out of the way to open up the space. And then they can do a fusion, where they go in there, clean it all up, and put in the screws in the cage. Each one of those is a little bit more than us. These 2, we actually do in the outpatient surgery center. That one's going to spend the night in the hospital. Like these ones come in, they have their surgery, and they stay with us about 3 hours, and then they go home. So back surgery's come a long way since even when I became a nurse. Let's talk about the cervical surgery. They go in through the front, okay? So your patient's gonna have a little scar right here. Their biggest complaint is gonna be
My throat is so sore.
Yes, it is, I know, because A, you had a tube rammed down your throat to breathe for you. B, they had to take the retractors and pull all your vocal cords out of the way so they could get to what they wanted to see. So yes, your throat is sore, I know that. Now, if they say, I can't breathe, that's a whole different problem. But if your throat's just sore, we can deal with that. That's gonna be their biggest complaint though. And actually, pain is my throat is sore, it's not my neck hurts, it's my throat is sore. Early ambulation, what you learn about that in peri-op? Okay, it prevents blood clots. What else does it do? It prevents atelectasis, pneumonia. What else does it do?
Helps with circulation.
It helps with circulation, so
Helps with
the blood
healing.
clots. What else? One other thing. I just had anesthesia. Everything was quiet and silent.
Because everything's
Oh.
moving again.
Yes,
So you don't get
it
constipated.
gets my bowels awake and moving again. So early ambulation, if your patient is able to get out of bed and walk, get them out of bed and make them walk. Now, if I go in there and I say, hi, Jessica, you gotta get up and walk this afternoon, okay? Justin's like, hell no, I had surgery, I'm not getting out of bed. So I'm gonna go in there and I'm gonna say, I'm
You
gonna
wanna
be
get up for
back at
breakfast
3
or
o'clock
lunch?
with your pain medicine, and then I'll be back at 3:30 and we'll walk down the hall. And Justin's more compliant because I didn't really give him a choice. I told him what we were gonna do. But if you just go in and, you know, oh, can you do this? And, yeah, they're not, okay? So a lot of times what you need the patient to do is all in the way you approach the patient. You know what I'm saying? You gotta be nice, but you still gotta get the job done. So I wanna get them up. Anterior approach. If I have a big hematoma right here, I'm gonna lose my airway. So do I need to be monitoring my dressing? And I need to be looking, making sure my patient's moving air, and then we're not closing off. So that's my biggest risk right here, is a bleed in the front that occludes my airway, okay? I don't want the patient to go, ooh, my neck feels really good now. Yeah, we don't do that. Cervical collar, most of them come out of the OR with the collar on, but the orders say that the collar's for comfort. And most patients like it when they're up moving around, and then when they're just sitting, they don't like it on, because it is really kind of constricting. It's just the soft collar, but they don't really like it. And it's only just for support, if they feel like their head's not supported. Now, the lumbar is a little bit different, because I'm going from the back, so I'm gonna still have some pain. I'm still gonna get them out of bed to walk, and they're still not gonna want to, but I'm still gonna do it. I'm just gonna tell y'all, I had a patient one time, and the order said to ambulate him. So me and my friend got him up out of bed, we ambulated him down the hall. That man didn't walk. I mean,
Y'all
he's been in a
drug him?
wheelchair for years. But we walked him down the hall. And so now, when I look at the patient, I'll say to the doctor, the order say to ambulate, but they came in a wheelchair. And he'll be like, oh, well, just do the best you can, get him out of the chair. But, you know, you gotta know your patient. Let's do a walk. His family was thrilled. You can assess the wound and the incision and the dressing on the guy's back. For bleeding, you're going to assess for a hematoma. So what would my hematoma look like back there?
Bruise.
I have like a big goose egg back there with a big bruise on it. But the most important thing is cerebral spinal fluid leak. So if my patient, I have him in the bed, and now I've got him up in the chair, and we get him out of the chair, and everything underneath him is wet, I got a problem. You know what I'm saying? Usually, if they have a big cerebral spinal fluid leak, what are they going to complain about?
Headache.
A headache. But sometimes if it's just a little oozy leak, you'll see the dressing be saturated, and you got to call a doctor, and they'll tell you to either reinforce it or change it or whatever. But cerebral spinal fluid leak on the back. I also want to do neurovascular checks on my lower extremities. So, do I need to know what he was like before he went to surgery? Clearly, that's a good thing to know. Did he have weakness in his right leg before the surgery and now it's better? Or is it worse? Or what do I need to tell the doctor? No lifting, bending, twisting for this person. I don't want them to bend down and lift and twist. Nothing greater than 10 pounds. No sleeping on their stomach. Does that make sense? Because if I sleep on my stomach and my back is like this, it takes the surgery and bows the surgery where he did it, and the results can be, the outcome that he wanted wasn't as good as what he hoped for. This slide is for you right here, future nurses. Lift with your legs, not with your back. You got to bathe a 300-pound bed-bound patient. Go get some help. If there's equipment in the hospital to help you move, turn, lift, use it. Learn how to use it. Don't ruin your backs. When you're working on somebody, lift that bed up to working height. Make sure you put it back down before you leave, though. Avoid prolonged sitting, exercise, keep your weight down. Stop smoking. Okay, I'm just telling you, smoking's bad for you all the way around, so stop smoking. But protect your backs, because you're just starting and you want your career to last a good long time, so you want to make sure that you're doing what you need to do to protect your back. Let's talk about spinal cord injuries quick, because they're the same as back injuries. It's a different source for the pain, but if I have a back injury in my neck or a spinal cord injury in my neck, are my deficits the same? Yeah. I mean, my pain's going to be the same. Here's the one difference, though. You can see this right here. Hyperflexion, this is the same as your head injury. Hyperextension, the same as your head injury. Stupidness, jumping off a bridge when the water is shallow, or falling off a ladder for compression fractures. Those are the most common. Your symptoms are the same. Here's your priority, though. ABCs first. My patient's got to be breathing, and if they have a cervical injury, there's a chance that they're not going to be breathing, okay? So I got to make sure that they're breathing, moving air, and they have some circulation. Then I want to stabilize their spine. Why is that?
So you don't cause any further damage.
Right, I'm trying to prevent a secondary complication, because if I have a cervical fracture and it's unstable, I'm going to cause other problems by just letting the head not be stable. I'm going to assess their Glasgow Coma scale just to see, are they oriented, do they know what's going on? And I'm going to check sensory motor if I can. Can you do most of this stuff before the ambulance gets there? Yeah, you can do a lot of it before they get there. So when they get there, you can tell them, you know, I've already done this, he's breathing, he's doing whatever. So those are your priority cares for immediately after the spinal cord injury. Here's some terms you need to know. Complete means you've severed the spinal cord completely in half. Incomplete means that it's partially, so your patient's going to have some deficits, but they're not going to be fully bilateral on both sides. They may have some use of a little bit. Tetra is the same thing as quadra. That's the new terminology, is tetraplegia. Okay? And paraplegia from, the chest down. So just make sure you know what those terms mean, because it makes a difference when you read the question. Your patient is a quadriplegic, and you want to get them up and walk them. Is that going to happen?
No.
Yeah, it's not. So you need to know what the term means. Level of injury. This just tells you that the higher the injury, the greater the loss of function. Okay, and then on this slide right here, it shows you in the red, if my injury is at that certain point, this is where my function is lost from here down. So you just need to kind of be aware of that. Like if you're looking at this slide, which ones of these patients is going to require your assistance with meals?
C4 and C6.
C4 and C6.
Yeah.
They're going to need your help a little bit. Which one of these is going to need your help with repositioning?
Top three. Well, they've got their arms, they can push a little bit, right?
Right, the top three are really going to need your assistance, especially the top two, but this one just to monitor for any kind of pressure sores or anything like that. This one, who has use of his full upper body, that's what the trapeze is for. I'm going to help turn you, but you need to reach up there and grab that trapeze and help me out here, So that's what you need to be thinking about when you're looking at if I say your patient has an injury at L1, what's my patient capable of? Can he feed himself? Can he communicate? Can he breathe on his own? That's what you kind of need to be aware of on that slide right there, okay? Nothing too complicated. It's more complicated in level 3 and 4. Spinal shock. You need to know this though. This happens with every person who has a spinal cord injury. This is temporary, and it's a complete loss of sensation, reflexes, the whole 9 yards. And it usually is resolved within about 48 hours. And when the reflexes start working again, that's when it's resolved. Because think about it, if you have swelling in your spinal column and now the edema is resolved, my reflexes don't have to go the whole way up to my brain. They're just automatic. They come up from the knee through the spinal cord and straight back down. I don't have to make that track to the brain to know, oh, you're gonna have that reflex. So that's how you know when it's over. The reason you need to understand what spinal shock is because in level 4, when we talk about neurogenic shock, they occur simultaneously, and you gotta be able to distinguish which one is which. So this is temporary, not life-threatening, happens to all spinal cord injuries, and usually is resolved in 48 hours. Okay? And the reason you know it's resolved is they have a return of their reflexes. Okay? Do those secondary injuries look the same as your brain injuries? Yeah, they're exactly the same thing. You're gonna bleed, you're gonna swell, you're not gonna get perfused, you know? So they're exactly the same. Can you see how it's just a big concept of preventing the secondary problems? It's not, I mean, they're all the same. I want to prevent these things from happening. Acute injuries, they go to the ICU. Through the ER to the ICU. Then they go to the floor for a little while, and then they usually go to rehab. So in here, we're going to talk about just acute, that just happened, what do I need to know about that? In level 3, we'll talk about when they're on the floor for the week, and then in level 4, we're going to talk about the rehab of them and what you're going to do. Can you take care of this dude all by yourself?
No.
No. Who are you going to call? Don't say Ghostbusters. Who are you going to call? Who's going to help you?
Neurologist,
Neurologist,
maybe a
Physical therapy.
neurosurgeon,
physical therapy, maybe a neurosurgeon, physical therapy,
occupational therapy.
occupational therapy. What about a dietitian? You think you need a dietitian?
Oh, yeah.
Yeah, because now this person's at risk for skin breakdown and constipation.